Sorry for the inconvenience, we were having some network issues. So a very good evening to everyone again. I am Dr. Shabnam Parveen, consultant in reproductive medicine and surgery, currently attached to Genome Fertility Center. Before starting, let me start with an interesting fact. We all know the term IVF or test tube baby, and we know that the number of couples requiring IVF procedures for different indications are rising day by day. But at the beginning of the era of IVF, the sole indication for IVF was tubal factor infertility. Which brings us to our first question: what is tubal factor infertility and how common it is? For a normal pregnancy to occur, we all know that we need a healthy egg and a healthy sperm. But to bring it together, the tube plays a very important role. The tube captures the egg and brings it to the site of fertilization. The sperm transport is also facilitated by the tube, and together it provides nourishment which helps in the embryo formation, and finally it transfers the embryo to the uterus where the implantation occurs and pregnancy occurs. If any damage occurs in the tube, either in its structure or function, it may lead to tubal factor infertility. Of the female factor infertility cases. Apart from this, 20 to 30% of the females who have undergone tubal sterilization, they also regret, and these also come under the category of tubal factor infertility. Coming to our next question, what are the causes of tubal factor infertility? The most common cause of tubal factor infertility is infection. More than 50% of the cases of tubal factor infertility is due to infection. The infection could be due to sexually transmitted infections like chlamydia or gonorrhea, or it could be due to tuberculosis. Apart from infections, previous history of pelvic surgery, endometriosis, all these may also lead to pelvic adhesions and finally tubal factor infertility. There is another section where due to mucus or secretion accumulation, there may be a temporary blockade, and this may lead to tubal factor infertility. Usually while we are doing a tubal patency test, then this is relieved, or we can also do a cannulation to remove this temporary blockade. Now, when should we evaluate these patients and how do we evaluate this patient? When a couple comes to us in our infertility clinic, what we usually do is we take a detailed history regarding any previous history of tuberculosis, endometriosis, previous pelvic surgeries or ectopic pregnancy. Anybody who is found to have a positive history, and if we do an initial TVS screening, an ultrasound shows certain positive findings which make us think that yes, this person may require a corrective surgery, then we directly go for laparoscopy. We do the corrective surgery as well as we do the tubal patency testing. Now, those who do not have a positive history or any positive findings during clinical examination or transvaginal ultrasonography, we can go for HSG or saline infusion sonography. So, in HSG, we usually instill dye into the uterus and we see whether the dye is coming out of the tubes or not by taking serial X-rays. In HSG, there is a problem. If we see there is a proximal tube blockage, that is a blockage which is near the uterus, then in 60% of the cases, if we do a repeat HSG or a laparoscopy, we find the tubes to be patent. The similar is the case for saline infusion sonography too. Also, in laparoscopy, which is considered the gold standard for tubal patency testing, 3% of the cases where bilateral tubal block is seen, pregnancy normally has been achieved. So, what are the other? There are some new methods by which now tubal patency test is being done, like gel foam infusion sonography as well as 3D SIS, which is making tubal factor infertility evaluation easier and easier by the day. Now, when should we evaluate for tuberculosis? We all know that tuberculosis is quite prevalent in our country as well as the neighboring countries, and it is also a mischievous infection. Why? Because sometimes we do not have any symptom, or there are some vague symptoms like menstrual abnormalities or white discharge, which people usually ignore, and therefore the diagnosis is missed. So therefore we should try to rule out tuberculosis in these patients. Patients which complain of menstrual irregularities or white discharge which is not being cured by the standard treatments, we should undergo an endometrial biopsy in these patients between the days of day 21 and 24 of menstrual cycle. After taking the biopsy, we can stain it, see it under the microscope, or we can culture it, and we can also go for a TB PCR. Usually if microscopy shows the bacilli or bacterial culture shows positive bacilli, then we go for treatment. If only TB PCR is positive, then we have to confirm it with the help of laparoscopy or any positive findings in transvaginal ultrasonography. In these patients, if there are positive signs, only then we start the treatment. Now, what are the modes of treatment? There are usually two modes of treatments. Either you have to go for surgery, corrective surgery, or you have to go for IVF. Now, there are certain determining factors which help in deciding whether to go for IVF or tubal surgery. In case the patient's age is less, the egg quality, the sperm quality is fine, previous pregnancy has occurred, the patient wants more than one pregnancies, and if the patient is not willing for IVF, then these patients can go for, we can suggest surgery. But before suggesting surgery, we should definitely see whether where the tubal block is, whether it's in the proximal part or in the distal half, and also how damaged the tubes are. Even in case of tubal ligation, whether reversal is possible, it depends on a number of factors. Now, we usually see even after the infection is resolved, sometimes due to distal tubal block, the tube is filled with fluids, and this is known as hydrosalpinx. Now, why are we discussing hydrosalpinx? Because the fluid which is found in this tube, this is said to be detrimental for the embryo as well as for the uterine lining. And if the fluid comes into the uterus, then this decreases the pregnancy rate as well as it increases the abortion rates. So, what is the solution? The solution is to either remove the tubes, or we can occlude the tubes by clipping or by cautery. So, in these cases, it has been seen that more than 50% pregnancy rate increase is seen if the tubes are occluded in IVF patients. How important it is to detect these sexually transmitted infections? Definitely, we should go for early detection and early treatment before any extensive damage has occurred and before a tubal blockage occurs. So, whenever a patient complains of white discharge, or which is foul smelling, itching, and if there is history of recurrent urinary tract infections, then she should definitely visit her gynecologist, get treated, get diagnosed, and get a full course of antibiotics. Otherwise, if left untreated, it may lead to tubal block. And when these same patients, they are going to conceive and they are finding it difficult to conceive, then they should consult a fertility consultant and they should see whether the tubes are blocked or not. And if tubal blockage is found, then they should discuss their options of IVF or surgery in such cases and decide accordingly on an individualized basis. Now, what is the management in case a patient is suffering from genital tuberculosis? Definitely, first we need to treat tuberculosis. So, for that a medical treatment is suggested for 6 months. In case the patient also has an abscess or a tubo-ovarian mass, then first surgical management, drainage of the abscess or removal of the tubo-ovarian mass is recommended before the medical management is started. Once the treatment course is complete, the patient has recovered, we can go for a laparoscopic tubal patency testing, and through that, if we find that the tubes are normal, patent, then we can go for natural conception, and also we can give her some ovulation induction drugs. Now, in case we see that the tubes are blocked but the uterine lining is fine, then we can suggest IVF. In such patients, there is a conception rate of almost 25% where the conception occurs. But in cases where the tubes are also affected and the uterine lining is also affected, in these patients it becomes very difficult to prepare the endometrium. There is recurrent thin endometrium, and ultimately if we are not able to prepare the endometrium, we have to resort to surrogacy. Now, in very rare cases, we see that the ovaries are also affected in tuberculosis. So, after giving multiple injections, the ovaries, they do not respond, and in these cases the last resort is adoption. Now, what are the complications which are associated with the fertility treatments that we give for tubal factor infertility? Now, due to tubal factor infertility, many a times not only the tubes are affected, we also know that the endometrium is also affected. So, in these patients, the pregnancy rate may decrease, the spontaneous miscarriage rate may increase. It has also been seen that whether or not surgery is done or not, the tubal pregnancy rates are increased in these patients. Also, when we are preparing these patients for IVF and we go for an ovum pickup, during that time, if we by mistake puncture the hydrosalpinx, or if there is any latent infection which is untreated, then it may lead to severe pelvic infection, pelvic abscess, ovarian abscess, and therefore in these cases it is very important to give good antibiotic coverage to prevent this. Finally, we go on to our last question, which is what is the success rate of the various treatments in tubal factor infertility and how we can enhance it. Now, we see that we know that there are two treatments. One is IVF, the other one is tubal surgeries. Now, in IVF, it has been seen that IVF for tubal factor infertility or IVF for any other cause, the success rate is almost the same. There is no difference. In case of tubal factor infertility, the deciding factor is the extent of the tubal damage and where the blockage has happened. If there is extensive damage, then surgery is not a good option because the success rates are low. But in case where there is mild damage, where there is no adhesion, and if the patient's age is less, then the success rate can be as high as 60%. Sometimes when we are doing laparoscopy, we see that the tubes are normal, but the tubes are attached to the other structures with bands which we call usually adhesions. So, if we slowly remove these adhesions and free the tube, then the tube and ovary relationship and the tube and the uterus relationship is again restored, and normal pregnancy can be achieved in 40% of the cases. If there is hydrosalpinx, how we can enhance this? I have already discussed that if there is hydrosalpinx, then we should definitely occlude, and this is going to enhance our IVF success rate. Also, early detection and early treatment of any kind of infection, sexually transmitted infection or tuberculosis, will help in enhancing the IVF results and the conception rates for these patients. Thank you. If you have liked this, kindly like this video and subscribe. If you have any queries, kindly contact us and we would be very happy to help you. Thank you.